Okay, question number 1. Is there any clinical tip from your side to minimize occlusal assessment?
Yeah, so if I heard that correctly, occlusal adjustment. Yeah, and it's really just following the tips I shared in this webinar. To minimize occlusal adjustment, you just need to ensure that you're giving your lab the best possible data to work with. A lot of labs, they also don't want to, have the reputation that their crowns are always high or the crowns have issues. And it's coming back to the fact that if your occlusal data that you're sending to the lab because you don't check it, if you just think you're going to scan this bite and it goes green and that's perfect, that's actually not the correct mentality, because the scanner will just capture the bite as you have it. So if the bite is open or closed or any issues like that, then you're going to be sending incorrect data to the lab, and that results in incorrect designs, incorrect manufacturing. That's all kind of a trickle down. So what I would really suggest is that when we take our bites, we check, make sure you've aligned it properly, and always check by rotating the scan that there's not a lot of intersections. And honestly, I just make it routine to scan both sides of the bite, and that solves most of my issues. If you do all of that and you're sure your data is correct and you're still getting high crowns, I'd have a chat with your lab and try troubleshoot why that is happening, because it also comes down to design and manufacturing.
Okay, thank you for answering that. Okay, question number 2. How do you take bite scan when patient has unstable occlusion due to tooth mobility?
Yeah, the bite scan if patients have a lot of tooth mobility, that's usually, periodontally compromised patients. And if they've got really a lot of mobility, I would assume you're scanning for an immediate denture or something. But anyway, for the sake of the question, you use your standard tricks. If the patient doesn't have a stable bite, you make it stable. And so if the patient's really compromised periodontally, you can splint the teeth. You can do all sorts of other tricks to try and make it stable. If the patient's missing a bunch of teeth and the remaining teeth are not very stable, you can use things like bite splints and any sort of occlusal appliance that you can put in the mouth, like bite blocks, and you can scan those out extra orally, and then just like you basically scan a denture and then do the bite that way. In general, though, what I would usually do, if I have a patient who's very periodontally compromised, a lot of mobile teeth, and I'm planning for a denture anyway, I would just scan as best as I can at roughly the OVD that I want, and then handle the rest on the CAD side. So you can have that dialogue with your lab, because oftentimes you'll be changing the OVD if it is a denture. But yeah, typically it really just depends on case by case, and when in doubt, splint the teeth and make sure the bite is stable.
I see. It means you want to make the patient has the stable bites due to splinting it, and then you do your treatment. Okay. Question number 3. How do you set occlusion when patient has bruxism?
Yeah, so if a patient has bruxism, and I'm assuming it's kind of like that first picture I showed with the really aggressive, worn down teeth. It really just depends. It depends on what you're doing. If, let's say, the patient just wants a night guard, they don't really have really bad bruxism, then there's 2 ways of doing it. You can just take your normal centric relation bite or maximal intercuspation bite, so just get them to bite down, as we've discussed, and take a bite. Or you can put a leaf gauge in their mouth and take an open bite. And that applies to your full mouth rehab cases as well. So as I mentioned about open bites, the scanner software does not close the bite automatically. Now that may sound annoying, but it's actually very useful, because if you open the patient's bite, you don't want the software closing it, because you usually want to open the patient's bite to a certain amount to either do a full wax up if it's a full mouth rehab, or for a night guard appliance. And so typically what I'm doing for these patients, if I'm just doing some, crown, let's say, I will just use their normal bite. But if I'm doing something like a full mouth rehab wax up or a night guard or a splint, then I would be opening them up with a leaf gauge to the, degree that I'm happy with, and how far you open them up is a whole different discussion. And then get them stable on that left gauge and take that bite, and you will see the bite is captured open. And that's exactly what you want to give to the lab.
So do you consider about selecting materials as well?
Yeah, of course. I mean, if it's a bruxism patient, I mean, we could have a long discussion about different splint materials, especially with the new 3D printed splint materials versus nylon versus, and in restorative cases, yeah, whether you prescribe or subscribe to this 3D printing revolution that's going on, or you just stick to materials like zirconia, that's a whole nother discussion.
Okay. Okay, last question is quite long. So yeah. Question number 4. After recording occlusion, the color map shows that patient has bite, which is too strong, and sometimes it appears as if the upper teeth are passing through the lower teeth, which would not really happen in reality. So how many millimeters of collision should I compensate for?
Yeah, and it's like what I was mentioning, intersections is probably the most common area that error that happens with bite scans. And as I was mentioning, look, if it's a few little spots throughout the bite scan, I'm typically okay with this. But if it's a significant intersection, and you will see it, it's not about millimeters, but you will see it. If you just turn the bite scan around so you can see through it, or you can see through the underside of the scan, as I was showing you guys, and you see a lot of intersection, that is when red flags arise. And typically what I would do is rescan. If you've taken 2 bite scans and this is happening, rescan, just delete the scans and do it again. But if you've only taken 1 scan on one side, do the opposing side. And that's really the solution for most intersection issues that I find, especially recently because Medit released that mandibular and occlusal analysis that happens after you take 2 scans. This happens automatically, and it helps reduce any intersections.
So you think that less intersection is quite okay?
Yeah, a little bit. I mean, if it's a little bit of spots here and there, I really don't find this to be super significant clinically. Of course, it's going to depend case by case, and honestly, have that discussion with your lab what they're comfortable with. But I don't really see these little tiny spots of intersection being an issue. I accept those. It's more so where it's like 2 millimeter, 2 millimeters, 3 millimeters, and an entire quadrant. That's when I see an issue.
Yeah, and also you explained that digital scan data and real impression is different due to PDL. So,
yeah, big time. And there's a lot of movement in the PDL, as we all know.
yeah.
So there is that discrepancy that always happens with the scan data. But like I say, as long as you're doing scans on both sides of the jaw and taking full light, you shouldn't have any issues.
Okay. That's all about it for today. So you'll be able to watch this webinar on our YouTube channel, Medit Academy. Thank you for being here, doctor.
Thank you so much, Jenny, and thanks again to the Medit team. See you guys later. Thanks for everyone out there watching.
Bye.